are different investigations that we'll want to carry out for lung cancer. A lot of these are quite general, but when we're investigating cancer, we need to look at the staging and the grading of the cancer. So the staging is going to be the spread of the cancer, and the grading is looking at how aggressive it is and how poorly differentiated it might be. So when we're looking at the staging, it's quite helpful to get a CT. This might be a PET CT or a CT with contrast. Looking at the grading, we need to get a sample of the tumour. This could be through bronchoscopy or through CT-guided pleural biopsy. I'll come back to this slide in a second. With bronchoscopy and CT-guided biopsy, it will depend on the location of the tumour. Your more central tumours are going to be much more easily accessed through bronchoscopy, and your peripheral tumours by CT-guided biopsy. These are some chest x-rays of patients with lung cancer. You might find it helpful to practice presenting them. The x-ray on the left shows a patient with a centrally located tumour, whereas the x-ray on the right shows widespread tumours throughout both lungs, and it looks like through each zone of the lung. This appearance on the right-hand side is what's known as cannonball Mets, and it's seen when renal cell carcinoma metastasises to the lungs. In terms of the management of lung cancer, this could be a combination of surgery, chemotherapy or radiotherapy. A general rule of thumb is that for non-small cell lung cancer, the patient will undergo chemoradiotherapy, and if it's a low grade, then they'll likely undergo surgery. That's because these patients have a better prognosis. For patients with small cell lung cancer, unfortunately, the tumours become resistant to chemotherapy after only a few months, and as small cell lung cancers metastasise early, often far in advance of them being detected, it's important to have them be involved with palliative care early in their treatment. There are a few other newer styles of management that have been brought in, and these are gene therapies and immunotherapy. When talking about gene therapy, we're mainly thinking about tyrosine kinase inhibitors. What happens is that cancer cells have this mutation of EGFR, which sends out signals that promote cell survival. So it's full of self-love, even though it's drastically flawed. And it's also sending out signals that are really important in the creation of more cancer cells. The tyrosine kinase inhibitors inhibit this EGFR and therefore result in tumour regression. The tumour regression can be really helpful in terms of reducing the tumour mass, but also reducing the symptoms that the patient is experiencing. As part of the body's immune system, T cells' job is to recognise and attack cancer cells. However, cancer cells can express something called PD-L1, and this tells the T cell not to attack. So the immunotherapy have created a drug which targets this PD-L1, by blocking that and then reversing this don't attack mechanism, the T cell can go back to doing what it would normally do, which is to attack the cancer cell. So I've left mesothelioma until the end. Mesothelioma is one of the diseases that's related to asbestos exposure, alongside other types of lung cancer and asbestosis, which is a type of diffuse parenchymal lung disease. So it's a tumour of the pleura. So if you remember, we have our lungs and they sit encased in a layer which is called the pleura. And inside that layer you have your pleural fluid. So a mesothelioma is when you have a tumour of the layer encasing the lungs. So this can result in shortness of breath, chest pain, as well as pleural effusion. When you're investigating it, you either want to get a biopsy of the pleura itself or take a sample of the pleural fluid and send for cytology. On a chest x-ray, mesothelioma can look a little bit like a cat hiding under a rug. So you can see here. What's also important to note is that mesothelioma, although it's related to asbestos exposure, it often won't present until many, many decades after the exposure. So that's everything that I had prepared for you on lung cancer. I hope that you found it helpful, and you can always go back and test yourself with the things that I put in the second slide. So goodbye and have a good day.